So welcome everybody, and we've got such a great turnout here. We're really, really excited about this. This is an important webinar. My name is Claire Betker. I'm the Scientific Director for the National Collaborating Center for Determinants of Health. And this is Strengthening Community Connections, a webinar that's profiling and basically introducing an incredible report by Kate Mulligan, Strengthening Community Connections, the Future of Public Health is at the neighborhood scale. So welcome everybody. And I'd like to start with the land acknowledgement. So I am in Treaty 1 territory. That's where I live and I work. And Treaty 1 territory is the traditional territory of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene people, and the homeland of the Métis. The center, the National Collaborating Center for Determinants of Health, is in Mi'kmaq, which is the ancestral and the unceded territory of the Mi'kmaq people, now known as Antigonish, or the center is located at St. Augustine University in Antigonish, Nova Scotia. And I think what's really important there is that that territory is covered by the treaties of peace and friendship, in which those peoples who first signed the treaty, it was not dealing with the surrender of lands and resources, but in fact recognized both the Mi'kmaq and the Maliseet title and established the rules for what was to be an ongoing relationship between nations. Okay, a bit of housekeeping before we get going. I'm going to ask that everybody mute. I can hear somebody right now. Everybody mute their microphone. So that we have only the speakers, and maybe, Diane, that's something that we could do. Thank you. So the National Collaborating Center for Determinants of Health, next slide, Diane, please, is one of six such centers, knowledge translation centers, located across the country. And we were established, which is interesting today, given where we're at, in the wake of SARS. So there's six of us, we're funded by the Public Health Agency of Canada, and we are all hosted by organizations across the country. So we've been in place for more than 15 years. So our center, next slide, the National Collaborating Center for Determinants of Health, and just to sort of set the context in terms of why this topic today, strengthening community connections, is so important to us. So our focus, and it has been since our inception, has been on the social conditions that influence health. And our intention is to narrow that gap between the least and the most healthy. And I think some of what you're going to hear today are some extraordinarily doable and practical ideas about how to do that from a public health as well as a community health and really from a societal perspective. Our main audience are Canadian public health practitioners, and we've got many of you here today, and welcome, thank you. Practitioners, decision makers, those that represent organizations, public health organizations, health organizations, as well as community organizations. But we also think about our researchers, students, and our partners. So today we had more than 300 people register for this session. We've got close to 150 here with us today. And I'm going to ask you to use that chat box. It's right at the bottom there. There's about 18, there's number 18 on it right now. And use that chat box to introduce yourself. Maybe say who you are, where you're from, and perhaps acknowledge the land, the traditional territory and the lands that you are on and that you're coming from. We have people from across Canada, but we also have people internationally with us here today. So the objectives for today's conversation is to share research and recommendations on how communities inform and support equitable health systems. We're also going to identify key actions to support community capacity and resilience. And then what's really exciting is we have a 5-person panel that is going to share their learnings from a very recent public health partnership related to Toronto. And Kate will introduce them. Okay, so next slide, and we'll get on to the meat of the webinar. And I'm just delighted to introduce Kate Mulligan, Dr. Kate Mulligan, who's going to give us about a 15-minute presentation on the report that she wrote. So Kate is a friend of ours and a friend of the National Collaborating Center for Determinants of Health and a friend of community health and public health. But she's also an assistant professor in the Dalla Lana School of Public Health at the University of Toronto. And her work there focuses on community health leadership through policy, advocacy, and intervention research, always related to health equity and to the social and structural determinants of health. She is a social prescribing advisor for the Canadian Red Cross. And what she's going to talk to you about today is a paper that she was commissioned, which is, I think, a very high honor, Kate, to have been asked to do that paper on strengthening community connections. And that was published both by the National Collaborating Center for Public Health, the main website, but it's also, you can find it on our website at the National Collaborating Center for Determinants of Health. So over to you, Kate, for your presentation. Just a reminder for folks to keep those mics muted until Kate is finished. Thank you. Over to you, Kate.
Thank you, Claire, and thank you to the NCCDH team for gathering us all here today and getting us through those early technical challenges. I know that can be stressful, and we were all feeling it along with you, so thanks again. Yes, my name is Kate Mulligan, and I'm speaking to you today from Toronto, which is the traditional territory of the Haudenosaunee, the Anishinaabe, and the Huron-Wendat people. And it's Dish with One Spoon Wampum Belt territory, where we learn from the leadership of Indigenous communities about caring for the resources and relationships here in the Great Lakes region. And I really want to acknowledge that, because a lot of what we'll be talking about today around strengthening communications strengthening connections and community connections has been, oh look, a software update popped up, has been really led by Indigenous communities. And also, there are some other communities that I'm really hoping that you'll be able to hear about today. So I'm grateful to be speaking to you from Toronto, where I'm also part of the Toronto Board of Health. And that's one of the spaces in which I learned about some of the amazing work that's happening here that I really felt needed to be shared. So I'm going to try to speak fairly briefly to the report. You can read it on the NCCDH website. Very shortly, in the next day or two, they'll also have a 4-page version available that really summarizes it more succinctly and also provides a few updates, because this report was written actually almost a year ago in May of 2021 as part of the inputs into Teresa Tam's annual report. So there are a few updates, a few updated resources, a few different case examples, and a much shorter version of the report for those of you who don't have a lot of time, and that'll be available too. But you can also look at the full report. So I'll go through it really quickly today. As I mentioned, this was commissioned by the Chief Public Health Officer of Canada, who asked for 4 independent reports into her thinking about the future of public health, particularly in this context of what we hope will be recovery to something better post-COVID. And so there are 4 reports that are available on the NCCPH, the National Collaborating Centers for Public Health website. So there's one about Indigenous health, one about governance, one about data, and then the one I was asked to do, which was about the role of community. What is the role of community, and what should be the role of community in a healthy and sustainable and resilient health system and public health system going forward? So that's really the question that I took away and did some research about. And I want to clarify here that when I'm talking about resilience, I'm talking about the systems themselves. It's not the same thing as asking people who live with oppression and communities who live with oppression and discrimination to somehow carry on heroically in the face of significant discrimination and challenges. This is about, at the system level, how can we work together and collaborate to cope with what's coming, to manage change, and to stay healthy and to bounce forward when challenges like pandemics arise, when challenges like climate change face us, when challenges like a massive opioid crisis are facing us. And you'll see a number of the graphics that I'm going to be using throughout this talk are from the World Health Organization. And I'll get into that a little bit in a minute. But we want to be able to invest in what they call primary health care, which is not the same thing as primary care, but is really about a linked public health, primary care, and community development approach at the local level. So I really begin here with the World Health Organization's framework on social determinants of health and the big arrow pointing to the meso level community. I think that in a lot of our thinking at the systems level, this level has been underexplored. You know, we do talk about public policies that we need to change. We do talk about individual level actions that need to change. We do less, not enough, about what actions are important at that community level. Policies that can help reduce vulnerability and build on community strengths and community capacities. So that's really the level. When I say the word community, this is what I'm talking about. A scale of intervention where we can take context-specific strategies that tackle the structures and the intermediate determinants of health. This report, very briefly on the methods, was a critical realist review. You know, typically for government reports, they want you to go off and do a very detailed survey of the literature. But when it comes to health equity, as many of you on this call will know, there sometimes isn't a lot of literature. There isn't a lot of new literature, particularly in a moment like COVID, about what community organizations are doing. Community organizations themselves are way underrepresented in the literature. You know, they're busy doing the work, they're under-resourced, as we'll see, they're under-relationshiped, and they're busy trying to make a difference in the lives of people. So we have to expand our thinking beyond just what is in academic publications to include key informant interviews with those people who are doing this work or know others and can make referrals and relationships, and then an advisory panel who can give advice to make sure that we're on the right track. And really a critical approach means thinking carefully as much about what's not there as what is there, and interrogating what's there from a lens of health equity. The last sort of overarching framework thing I want to share with you is this really important paper by Emma Sachs and her colleagues called Beyond the World Health Organization's Health System Building Blocks. And you can Google that, and I'll try to pop the link into the chat later on as well. What this shows is in the sort of orangey color, the traditional 6 building blocks of health systems that the WHO uses to say what we need in a good health system. And what's missing is community. And so this paper adds in several of the locations in which community is already part of health systems, not could be added to health systems, but typically is already part of health systems, but tends to be ignored, invisibilized, under-resourced, and so on. So we're involved in service delivery, in the health workforce, in household production of health and the social determinants of health, through community organizations and through societal partnerships, as well as through information, learning, and accountability. These are the ways in which community is already present in what you're doing. And one of the things that I want to share in this report is to really surface that, to make it less invisible, and to provide the resources, relationships, and supports to be able to learn from that tremendous capacity that is available in community. So the report comes with 4 key recommendations, and here's the first one: resource community health. Give community health access to the money, the relationships, the supports that are needed to do the work that they need to do. And as the World Health Organization says, an empowered, vocal, and engaged community is necessary to achieve reliable and resilient primary health care. And this has been something that's been called for globally for years under the Alma-Ata Declaration back in 1978, in the Ottawa Charter for Health Promotion in 1986, which called for us to reorient health services toward addressing community health and health equity and health promotion. And also in the more recent Astana Declaration that renewed the commitment to a comprehensive approach to community health and primary health care. So this is what the WHO model looks like. It really brings together multi-sectoral policy and action, empowered people and communities, and primary care and essential public health functions together as the core of integrated health services. And through the example of this incredible panel from Toronto, you're going to get a sense of how that can work and how people can build that kind of work at the local level. And I want us to start getting used to that terminology around primary health care. I know in Canada, we tend to think of primary care as purely clinical, maybe an individual physician or nurse practitioner providing services, or if you're lucky, a team. But primary health care is something even more comprehensive, and it really includes all of this. Sometimes we see good examples of this within organizations or within teams of organizations. And we want to really grow that work and sustain it, because it's what we need to have equitable healthcare going forward. Secondly, we need to be accountable to communities. We need to put our money where our mouth is, where our mouths are. And that means working with, again, the community's expertise and valuing their time, valuing that expertise, again, providing the funding supports and other resources that are necessary to use that time. At minimum, that shouldn't mean community engagement, working with communities, but ideally we're doing more. We're doing co-production or co-design. We're doing participatory and community governance, things like having community boards, ensuring that Indigenous health is in Indigenous hands, making sure there are public representatives on boards of health, like Toronto has, for example. These are some of the ways in which you can build in structures of accountability. And again, this is another way of looking at it. We want to move from that upper left quadrant to the bottom right quadrant. We want to move away from things being done to us, without us, and we don't want that charitable model where things are done for us, but we're not included. You know, in some cases, we've managed to get to nothing for us without us, or nothing about us without us. And there are good examples of this through, for example, people who use drugs, taking leadership in their own communities and ensuring that their voices are at the table and their expertise is at the table, expertise that no one else has. And if we want to be able to access that, which is sometimes the only piece that's really going to be effective and sustainable, we need to really, really think about how we're including people. But ideally, again, we want to move to being done by us, for us, where community takes the lead and the resources and supports come wrapped around that in true partnership or in support. Next, we want to build community and equity into the data, right? Until we can track who's being left behind, health for all will remain an empty promise. We saw a strong example of this, again, in Toronto during the pandemic. When it was the Board of Health and then Toronto Public Health that were able to step up early to require the collection and use of sociodemographic and race-based data. This wasn't being collected before and still isn't in many parts of Canada. But it was essential to our understanding of who was being most impacted by the pandemic. And it helped underpin the community responses that the city was able to engage in going forward, that you're going to hear about. That said, if you're not having community governance over those data, you're not there yet. So we can't just use these data. Our histories show that without data sovereignty, there will not be trust that this data will be used appropriately, because there's a long history of it being used inappropriately and against the interests of the people whose data it really is. So these are two models that show a way forward. The OCAP principles for ownership, control, access, and possession of First Nations data, for example, and that's one example of how Indigenous communities have, again, led the way on what data sovereignty can really look like. And then this other is from a Black Health coalition coming together to talk about engagement, governance, access, and protection for Black communities, where data sovereignty is also very important and is something that we need to make sure is included in all the data collection, all the use, so that these data are used appropriately and with the expertise of the communities who are most impacted. The last one I'm going to mention today is to confront the causes of the causes. This will help us take the multi-sectoral actions and policies that really address the underlying causes of poor health. And we are really not there yet in Canada. Again, Indigenous communities have really led the way on naming and confronting colonialism as a driver of Indigenous health and well-being. It's a driver of all of our health and well-being too, in different ways. And we need to really think about the structures that we've inherited and how we might be inhibited by those, what barriers they might pose, and how we can change them. And this includes not only, understanding the why, not just that we have geographic inequities in health here in Toronto, some neighborhoods being more at risk than others, but why? Why is it that? Why are certain housing patterns, economic patterns, employment patterns, and so on? Why are they racialized? Why are they stratified by income? What is happening to create this exclusion or discrimination, and so on? So these are just two quick examples from Canada. A history of eugenics and public health. We need to look closely at public health's connection with that, and the early adoption of public health in an industrial era, whereby it was used right off the bat here in Canada to include and exclude immigrants on various bases that were rooted in eugenics. If you were disabled, if you were otherwise undesirable, for example, you may be excluded from immigration. And certainly that similar approaches were taken within country as well. And the other one on the other side shows the Saskatchewan doctor strike during the institution of Medicare in the 1960s. And this one I show because it just reminds us that what the legacy of this particular strike is fee-for-service medicine, that doctors at this time didn't want to change the structure that had been in place since the colonial era, since the founding of Canada as a country, that privileged their position as entrepreneurs and business owners. We still have that legacy, even though many physicians would like to be able to operate under different models. Many other health professions have emerged. Many other ways of doing things have come along, but we've still inherited that legacy. That's something we can change. And it's a reminder to all of us that many of these structures are changeable, but we need to ask more questions about where they came from. So I'll just wrap it up by saying we want to, with an approach to community, keep focusing on what's strong over what's wrong. Linking to the strengths in community, the incredible capacity that communities have to build trust, to lead their own healthcare. This capacity has always been there. It hasn't always been heard. We shouldn't have to have the data at hand when communities are already telling us what's happening where they are. Right? There has to be some epistemic justice for the worldviews, experiences, and knowledge of communities, and all that they have to offer that no other parts of the health system have access to without this partnership. So through things like using community ambassadors and linking different community and health organizations, Toronto was able to make a real difference on vaccination and other COVID response. There are other amazing examples of this across the country as well, but I hope you'll join me in really celebrating the work and the leadership of those doing the work in Toronto by listening and asking as many questions as you can of them about their case example for today. Thanks so much for having me here, and let's look forward to the panel.
Thank you, Kate. And I'm just going to look for the applause hand there. There it is. Yes, as we applaud Kate. That was a super presentation today, Kate, but what a great paper and what a great legacy that you're leaving for our system as we move forward. And so with no further ado, I'm going to move to our esteemed panel. And what I'm hoping is that we can see, they'll turn their cameras on. So I'm going to ask all of you who are on the panel to open your camera. But just while we're doing that, a couple more housekeeping. Few of you joined us while Kate was presenting, so I'm going to ask you to use the chat box at the bottom there to introduce yourselves, maybe give a land acknowledgement, and say where you're from and who you're representing, please. And also use that chat box for any questions, because I think there'll be questions for Kate, and there's also going to be questions for our panel. And while you're kind of orienting yourself to that chat box, I just want to acknowledge, behind the scenes, there's always people just keeping things going and making sure that these types of events happen. So I just want to acknowledge 3 of our staff at the National Collaborating Center for Determinants of Health. First, Diane Oikel, second, Nandini Saxena, and third, Midian Richard. And those are our knowledge translation specialists. They're watching that chat box. They're helping with gathering the questions, and they're also populating it with some of our resources. If you have resources that you think would be helpful to this group, also please use that chat box to put a link into it and to communicate with each other. Okay, so we're going to go to our panel. And each of these folks played a critical role in, I think, really illustrating what Kate profiled there from her report and from that the 4 key actions. So I'm going to start with Safiya Ahmed, and she is the Executive Director at the Rexall Community Health Center. I'm going to ask each of them to give a little bit of background about themselves. But the question for Safiya is, when this work started, and you'll describe a little bit about the work, how did you get it started when there was so little support, as Kate had profiled, for that work? And we're hoping that you can highlight those critical relationships and the critical resources that you were able to tap into. So Safiya, over to you.
Okay, well, thank you, Claire, and thank you for the organizers of the conference for this invitation and this opportunity to share our learnings. Let me start with land acknowledgement. I would like to start by honoring the land that we're on, which has been the site of human activity since time immemorial. It's the traditional territories of the Huron-Wendat, Anishinaabeg, the Chippewa, and Haudenosaunee Confederacy, and most recently the Mississauga of Credit Rivers. I would like to say that we are all territory people, and some of us came here as immigrants and newcomers, I being one of them. And I would like also to acknowledge those who came here forcibly and honor and pay tribute to the ancestors of African origin and descendants. So with that, let me just give you a bit of a background of where I work and my organization. The Rexall Community Health Center provides primary healthcare services, and I say primary healthcare services as being distinct from primary care, and health promotion, community development, and capacity building to the residents of North Etobicoke in the Northwest Quadrant in the city of Toronto. Our interprofessional teams work with our community by addressing, primary care, health, physical health, mental health, and also addressing social determinants of health. So if I sort of pivot to the question that you've asked about the initial responses and what we were able to, how we were able to address COVID-19 in our community, let me start by saying that the initial public health measures and the lockdown protected Toronto's high-income neighborhoods, while it made little or no difference in communities like ours. By June 2020, COVID-19 rates were more than 10% higher in low-income racialized neighborhoods like ours compared to healthier and more central areas in Toronto. In fact, the neighborhood with the most cases was Mount Olive, Jamestown, which happened to be in our catchment area. We were able to utilize existing data and gather feedback through virtual focus groups, interviews with partners, clients, and community members, and confirmed the following. Now, first, earlier public health messages to self-isolate, to work from home, did not reflect many people's experience and did not resonate with community like ours, who, most people were frontline workers, PSWs, taxi drivers, factory workers. COVID-19 positive diagnosis came with increased burden in low-income racialized communities with higher social and financial costs, risks to family members, and large and growing impact on food insecurity, housing insecurity, and job insecurity. Misinformation and stigma associated with being COVID-19 positivity compounded the burden of the pandemic in this community. We also had only one hospital-run drive-through testing site in North Etobicoke, which presented significant access issues for those without easy transportation options. And in fact, through some of the interviews, we came across one senior who shared with us that she wanted to get testing, COVID testing, and she had to take a cab, waited in line to access testing, and ended up with a significant bill. The community also shared with us that COVID response was poorly resourced and poorly coordinated, and supports for those who test positive were disorganized. Local agencies were trying to fill the gaps and using volunteer resources, while COVID-19 funding flows was going to other parts of the system. So through that process, we were able to gather some recommendations from our community members and partners. So people wanted accessible testing, COVID-19 testing sites that are accessible to them, were open weekdays, weekends, evenings, mobile pop-ups, tailored messaging that reflected the experience of the residents and coming from trusted community leaders and agencies. Also addressing fear and stigma at every step in the process, utilizing multiple and appropriate platforms and languages to disseminate information. One of the things that community members highlighted and shared with us was to build trust through consistency and presence in the community. People were reluctant to actually believe that we are going to be there, and the services will be there to support them throughout the pandemic. So we're looking for consistency and presence in the community. And also to provide coordinated wraparound supports available for those who need to either self-isolate or who test positive. So at the North Etobicoke cluster table, a COVID-19 response planning table with 34 community partners and chaired by the United Way and the City of Toronto, we came together and collaborated to set up a community testing site at the Rexdale Community Hub. The Rexdale Community Center, Community Health Center, deployed some of its nursing staff to support the testing site. Our partners deployed staff. We also engaged community leaders and volunteers to support outreach, information sharing, and awareness. Our partners also deployed some of their staff to help with case management, service delivery, to provide wraparound supports to address food insecurity, housing insecurity, and mental health needs. We also approached Central West Ontario Health Leadership to help us with IPAC, logistics, staffing, and also to help us design the testing site. In fact, this testing site still supports our community and provides testing to our community. Just to give you a bit of how we went about it. So when we set up the testing site, we invited community leaders to do a walkthrough and community members to walk through so that we can incorporate their feedback into setting up the testing site. We got really rich information back, and whether it was just having additional signage, engaging folks while they were waiting for the testing to be done, and also identifying some other challenges around hours. And the initial pilot, we did it on a Friday, and the feedback was that Friday was not a good day to do that. So we were able to incorporate all of that into the design and into the operations of the testing center. I would like to say that these initial strategies actually informed our COVID-19 response throughout. Drawing from the data and community feedback was significant in marshalling resources on the ground, responses directly connected with the community and what they told us they needed, collaborating with community leaders, ambassadors, and volunteers, and building trust, and also being able to pivot resources in response to community needs. All of these strategies became foundational to our COVID-19 vaccine campaigns and to also the high priority community strategy, which followed thereafter. And hopefully we hope that this equity-driven strategy become foundational as we prepare for recovery beyond COVID-19. I think I've sort of had 3 minutes to do this, and I look forward to your questions. I have a lot more to share. Thank you so much.
Thank you, Sophia. So incredible resources. Marshalling, I like that word, I think is what you use, marshal those community resources. And began with the community, began with gathering the community, bringing those community leaders together and moving that forward. And I too hope that that legacy remains as we move ahead. Andrew, Dr. Andrew Bazari is the Executive Director for Population Health and Social Medicine at the University Health Network in Toronto. And so, Andrew, from your perspective, sort of building on Sophia's story, how did you share hospital or formal health system, acute care perhaps, resources, and then build upon relationships with the community sector? And you can start by introducing yourself, Andrew. And thanks for being here.
Thank you, Claire, and thank you to Sophia for the tremendous start. And I think it just in terms of centering myself as to where we are and where I am on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Wendat people, and currently under Treaty 13 of home to many First Nations, Inuit and Métis people. And I, as a son of a refugee and immigrant here in Toronto, and now having the privilege of working as a primary care physician and executive director of the UHN Social Medicine Center. I mean, I really think in terms of just the centering, and I appreciate the question, Claire, around the sort of sharing of resources. I do think one of the major pieces that we have to address, and Kate did such a great job in the presentation, though, is to me from the hospital or acute care sector, in terms of grounding ourselves in humility. I think that has not been the case of the hospital sector in terms of the disproportionate aspect of, we talked about resources, in terms of the underfunding in communities. And I think for us, and I think this is where many of us are working in these spaces in acute care, or at the intersection of hospital and community, is the continued efforts to see a shift as to our notions of health. And if it is a university health network and not the university healthcare network, the way that we think about our resources and partnerships, I would argue, not just engagement, are really important. And I think as we've seen this through the pandemic in terms of the community leadership that was there, I mean, when you look at the question in terms of, why would we share hospital resources? I think one, it's really clear just again about the disproportionate impact that we've seen, as Sophia has laid out, of the Toronto Public Health data that was available, of more than 80% of the cases happening in racialized communities, more than 50% of the cases happening in low-income neighborhoods. And again, that wasn't always the case, as Kate mentioned, in terms of the beginning of the pandemic. There was actually public health officials and healthcare leaders who are saying, we don't need to collect this data. We've not historically. And I think being able to illuminate that, being able to see where the hurt and suffering and burden was taking place would only necessitate us moving in a different way and sharing things differently. I also think it's really important that we talk about the systemic discrimination that took place around where vaccines were going initially, and again about the hospitals. For sure the vaccine's moving, but it was not making it out to communities. And more importantly, I would argue, it was not making it out into racialized and low-income communities. And we saw this with the data very early on, where it was affluent neighborhoods that had almost no COVID risk or much lower risks. They were not in the double digits of COVID test positivity, having an abundance of vaccine access. And it was not the case. And we saw the lineups and the leadership that had to take place to get the vaccine out. And I think this was part of, the shift of understanding this had to happen. And I think, again, in terms of the theme of humility in hospitals or acute care, again, in drawing on the report, it's important to situate ourselves that for many of us working as physicians or in different aspects of the healthcare system or acute care system, we have not, as associations or an institution, always been aligned with progress. There's examples there of doctors protesting against universal healthcare, positions by certain associations, physician associations that have not been aligned with these elements. And so I think it's no longer just about thinking about sharing, but what is equitable resource and partnership having to look like, and being able to acknowledge and assess when we are standing in the way of health, standing in the way of progress, and not allowing these disparities to continue both within resources and in the way that care is delivered. So I really appreciate the invitation, and obviously looking forward to the discussion that is coming up.
Thank you, Andrew. And you make some really, really critical points and built really well on what Safia had said. And, I'm a registered nurse, so a regulated health professional as well. And one of my mentors said to me one day that social justice, Claire, is a manifestation of our caring. So, have we actually lost those roots and lost that perspective? So yes, I look forward to questions. Use that chat box. So thanks, Andrew. So now I'm going to introduce Joe Cressy. Joe is the chair of the Toronto Board of Health. And Joe, really, we're interested in what your role was, what you saw as the role of the board, and how you were successful in emphasizing equity and really that whole of government response. And if you could start, Joe, with an introduction of yourself and then the question. And you can see these layers and levels that Kate outlined in her paper, sort of coming to be in this conversation. So over to you, Joe.
Well, thank you, Claire. I should start off that I'm quite humbled to join my fellow panelists here, who are just remarkable, and it's a privilege to follow Safia and Andrew. In introducing myself, I have the privilege of chairing the Toronto Board of Health, which oversees Toronto Public Health, our public health unit. But I also have the privilege of serving alongside Kate Mulligan. And I operate on the principle of do what Kate says, because we're better off when we do. And so, Kate, thank you for that presentation. I do chair the Board of Health at the City of Toronto, as well as I serve as a city councillor. And through this pandemic, for the last 2.5 years, I've served on our city's strategic COVID command team and our immunization task force. To situate myself here, I am in Toronto at my desk, which of course is the traditional territory of many, many nations. From the Anishinaabe to the Haudenosaunee to the Wendat peoples and the Mississaugas of the Credit. And it is indeed now home to many First Nations, Inuit, and Métis peoples. And it is by luck and privilege that I get to walk on their territory. In the context of my role, and maybe to anchor that in the City of Toronto, in overseeing Toronto Public Health and in working alongside our mayor and various city divisions on our COVID command team, our work has been here to respond to COVID, to implement a vaccination campaign, and to be part of an integrated model of care and recovery as we look to go forward. I think we have taken the sort of the foundational starting point that we should at first and foremost at all times follow the science. That secondly, act quickly, act fast. And third, all decisions ought to be and should be at all times anchored in equity. Those have been sort of in our attempts, not that we've been perfect, in our attempts, those have been sort of the three overarching principles. In seeking to implement those principles from a science, a proactive, quick response, and an equity framework, at the Board of Health, there's sort of three things I think that really tried to move us in that direction. The first was data. This has been referenced by Safia from early on in the absence of proper data, and by Andrew and Kate, and when the data became collected. is in the spring of 2020, in the absence of data being collected through our provincial government, it was the direction of our board to Toronto Public Health to collect disaggregated data on COVID cases and to break it down by race, by income, by housing status, by employment. And at the time, we were one of the first public health units in Canada, not the first, but one of, to do so. And the results, I mean, listen, the results demonstrated that which those of us who have engaged in social justice work for a long time were not surprised by. This pandemic was disproportionately impacting marginalized communities, and it was exacerbating this. So the first piece for us was to collect that data, not for the sake of collecting that data, but to inform a roadmap to action. Data is not the endpoint. Data, when collected and co-designed and co-collected appropriately, creates the roadmap to action. So collecting the data was first. The second piece from a municipal and public health side was at the direction of the Board of Health, we established a COVID-19 equity action plan for the city of Toronto. The principle here was that an equity-based response to COVID needed to be every division within the city's purview. You know, equity is not the responsibility of social development in that department or Toronto Public Health. It is every division. And so every division and department at the city was tasked in 2020 with developing their own equity actions, their indicators for risk and their actions to address it. And then the third component here in again, trying to follow the science to act quickly and to embed equity, was to learn from and invest in community. And from, Safia spoke to in the early days, ensuring that testing was actually accessible, ensuring that there was the outreach to enable access to testing, but importantly is to ensure that people had the resources, should they test positive, to access food support, income support, sick leave, isolation facilities. So to learn from and invest in community initially in not only access to testing, but the wraparound supports to enable people to cope. And then later on to learn from and invest in the vaccination campaign at a community-based level, from ambassadors to community agencies. And so that's been where my work has been. Listen, in the context of our city, as you'll hear from others, this pandemic exposed the deep inequities that existed prior to this pandemic and were exacerbated through this pandemic. We sought at the Board of Health to identify and mitigate those impacts, to create systems that could help to build a better normal. But we tried at all times to be rooted in equity and community. We were not perfect, but I think some new models have been created, some silos have been broken down around the provision of health and social and community services that can put us in a better place going forward. And it's grounded in community. And that has to be the path. So Claire, I hope that wasn't too long to kick it off, and it's just a privilege to be here.
Thanks, Joe. And I'm just going to remind folks again about the chat box and about questions. I think we will have some time for some questions. Unfortunately, Safia has to leave us, so I'm just going to turn the mic back to her for a moment. You've heard two other speakers, Safia, and just ask if you could, give us some closing words as you go about your work today. And thank you so much for your perspective and for kicking off or starting us in this panel in such a good way. So over to you, Safia.
I think one of the key messages that I would like to impart with today is building sustainable relationships, gaining trust, and also recognizing that in order for us to be smarter, faster, and more responsive to our community, we need to really create those collaborative efforts and make sure that we are, as I said earlier on, marshaling the resources on the ground. So I don't think we would have been able to do the response that we were able to how we were able to respond to our community would not have been possible without marshaling those resources and the coalition of the willing, whether it was the hospitals later on who were helping with the vaccination and providing the staffing, whether it's our community partners who were deploying their staff to help with case management, delivery of food, making sure that mental health services were open and provided to community members, or whether it's basically taking advantage of the incredible resources that are available at the community level. Communities know what they want. And in some cases, in many cases, they have the answers themselves. So it's really creating those opportunities for communities to lead and to have those resources available so that we can, be more smarter, faster, and more efficient in our response.
Thank you, Safia, and thank you for the work that you do every day. Thank you, and thank for making the time for us today.
It's a great pleasure to be here today, and I thank all the presenters and everybody who's been here. And Kate, that was a fantastic report. Thank you, Claire.
Yeah, bye now. Okay, so we're going to go on. We have two more speakers, and then we will have time for questions from the audience. There's a couple that have been coming in through the chat box. I'm going to encourage you to continue to ask those. So the next two people, and I had said earlier that our audience in the National Collaborating Centers, or Collaborating Center for Determinants of Health, is public health organizations, public health practitioners. And those are present across our country, coast to coast to coast. And I give them great thanks for all of the effort and hard work over the last 2 years. But the next two speakers, Jeff and Daniel, are part of that public health and that more formal organization. So Jeff, I'm going to go to you. Jeff Gillard is the manager of infection control and infectious diseases with the City of Toronto. And Jeff, if you can just talk a little bit to why did Toronto Public Health get started with those community partnerships? And I think Andrew made a very good point as he made the distinction between community engagement and partnership, sort of shifting to that notion of partnership. So how did you, or why did you get started with that during COVID? And what were some of your first steps as you moved forward? So over to you, Jeff.
Thanks very much, Claire. It is an honor to be part of this panel and to follow these other leaders who have spoken before, and Daniel is going to come after. I do want to acknowledge that as a resident, like my other panelists, of Toronto, and particularly as a resident of the neighborhood of Regent Park, which sits right on the banks of the Don River, which is so historic and significant to the city, that I do reside on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and do come under, of course, the Treaty 13 that was signed with the Mississaugas of the Credit. So it's a real privilege to be here with you today. So to your question, first I do, as Safia did, want to just situate myself a little bit. So I am the lead for the community engagement campaign related to COVID-19 for Toronto Public Health, but I really want to acknowledge that while I am the person who maybe plays a point role and people come to when they want to either connect to community from our own organization, or when there are questions and challenges being experienced that I can maybe connect to people within Toronto Public Health to help solve. There are many people within Toronto Public Health who play direct and indirect roles in supporting our partnerships and the whole community engagement system that's been created to support the response to this pandemic, from community health officers and our associate medical officers of health, and also our immunization teams who work directly with community as well. But I do have the privilege of playing that sort of lead and connector role. And in terms of why public health got started, I mean, we've already spoken, others have spoken, more eloquently than I could about the inequities that we've seen from the beginning of this pandemic, but we've also seen prior to this pandemic, and we knew that the sort of scale and scope of the response that was needed here required an effort to build those partnerships, to build on the partnerships that existed, and to create structures and resources that went beyond what we maybe have done in the past even. So, you know, it's really about, you know, optimizing and really taking our goals around equity and making sure that we are getting people vaccinated in those communities that experience barriers and concerns around the vaccine that go beyond what are seen in other parts of the city, making sure that we're supporting vaccination in those communities as much as possible. So you know, then it's how do we do that? So, you know, we have teams within Toronto Public Health that do an incredible job of tracking new information as it emerges, packaging it in ways that can be easily shared. But we need those partnerships and really the vaccine engagement teams, which I know Daniel will talk more about, have been really key in helping us to amplify and get those tools and information resources to people that we just couldn't reach on our own. And that whole idea of the trusted peer and the power of having information shared by peers is something we really wanted to emphasize. So that was a key piece. And then, you know, as Councillor Cressy talked about, evidence has to drive this whole response, evidence and data. And you know, one of the things that the types of conversation that I have most frequently with people within Toronto Public Health about our work is really what we can learn from community and from our partners that helps us to understand better the data and in a more granular form. So, you know, how we understand what's happening in more specific parts of the community that the data doesn't always get us to. So that's been a really critical piece. It's such an important part of the evidence. And in fact, just today, I shared one of the biweekly reports we receive from the vaccine engagement teams and ambassadors. And immediately I have 3 emails, you know, asking, you know, I want to know more about this. Can you find out? And so there's a real hunger for that. And there's a real recognition within Toronto Public Health that the data can take us so far, notwithstanding all the issues with data and limitations, but we really need that community insight and those community perspectives. In terms of the first steps, you know, it's been interesting to just think about this and go back to the beginning of this work. I mean, in terms of Toronto Public Health, we are not the lead part of the city, sort of division within the city, in terms of supporting directly and overseeing all of the work of the vaccine engagement team. So our role really was to work closely with the part of the city that Daniel is going to represent and will speak about, to really sort of think through how to set up this whole vaccine engagement team and set up partnerships, and how to support them in the work that they did. As Safia said, they know what's needed. They know what to do. So the question is, how do we support that? And that was really, you know, largely what took up the early days and the formation of this whole piece. And it really led to making sure that we created regular touch points and connections with our Associate Medical Officer of Health responsible for vaccine information, really connected to the whole you know, National Advisory Committee set of updates. And it was really about keeping people informed about vaccine and vaccination on an ongoing basis so they can share that information. And then having those regular touch points with our data team and doing workshops with the vaccine engagement teams to not only have them understand the data that we're providing, but also how to go in and use the data that we're updating on a daily basis. So I think Daniel will talk more about kind of how the vaccine engagement teams and that whole supporting that set of partnerships works. But in the early days, that's really what we really emphasized and focused on. So yeah, I mean, I'm sure more will come out through the questions, but there's a starting point in terms of understanding our work and our emphasis here. Thanks.
Great, and thanks, Jeff. And there's many online that are managers and practitioners or directors where they're working in what I often, and as you were talking, that image came to me of kind of a middle space, right? Sort of in that intersection between multiple parts of the system. So thanks for that. And those reflections, I think, are really important. And you also emphasize the importance of communication and the mechanisms of communication, which I think is super important. And the privileging of all types of evidence, right? Not just data or data-driven kinds of evidence. So thank you for that. So Daniel Bondi is a project manager for vaccine engagement, and he's going to be our final speaker. And then again, just please, I've got a couple of questions that I've seen here, but use the chat to ask a question of one of or all of the panel, or Kate. Over to you, Daniel.
Many thanks, Claire, and privileged to be here, privileged to both be on the panel, be a part of the conversation, but also to stand and be in Toronto, where I am right now, land that is covered by Treaty 13 and the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. It's a privilege to continue on in the work of co-creation and community development that is as old as time itself. As was mentioned, for those that may not know me, my name is Daniel. I am a project manager with the city's community development unit, specifically housed within the division of social development at the city, whose real focus is around partnership development at the local level, resident leadership, capacity building. And if it would say the secret sauce for that division is focus on equity, its resolute posture and position on equity. And over the course of the past year, I have had the privilege of leading and supporting the evolution of our vaccine engagement teams that you've heard a little bit about. I'm just going to unpack a little bit about what exactly are vaccine engagement teams, because I think that will help inform the dialogue, the conversation, and the panel discussion, but as well, I think it responds to some of the questions that I've seen already come our way. And it starts with the beginning of the vaccine program at the early days. And at the onset of that, recognizing that public health recommendations for the vaccine are only as effective as they are trusted. And in its simplest form, in its most pure form, that is exactly the role of a vaccine engagement teams: to build, to bridge, and to broker that trust. Broker that with community, with residents in the community, and with the municipality. They themselves have this laser focus on their goal, which is to create a more inclusive and accessible and equitable vaccine program. And they do that through hyperlocal and equity-focused engagements. The teams themselves across the city in different clusters bring both population and place-based approaches to their work. We'll bring together over 200 health, community, and faith-based organizations. And it's important to know that these teams bring together not just the usual suspects that you would consider inside of a vaccine rollout or a vaccine engagement program, but a mosaic really of all the social service providers in the landscape of the for-public benefit sector inside of those clusters, those areas, and those communities. And they bring them into concert with each other. Again, not just health or multi-service organizations, but faith-based organizations, newcomer settlement agencies, grassroots resident groups, ethnic, culturally focused service providers, arts-based organizations even, and population-specific, as the rollout has expanded its registration for youth, for seniors, and we continue to expand these memberships as far and wide as we can, really to make sure that it's as whole and as complete as possible. And it's also important to note that these engagement approaches that they take are incredibly customized and dynamic. There's really isn't a static version of what happens. There's cross-pollinations and learnings that are shared all the time, and we want to really help facilitate and nurture that conversation. But those engagement approaches that are delivered on the ground day in, day out, have been for the course of the last year, are as customized by language, making sure that there's specific interpretation or promotional tools that are available to access the information, or even leveraging the formal or informal networks that ambassadors or residents or networks or service providers have in those spaces, or even considering the unique approaches that might be needed within a city block or a city street even, or even a city tower, recognizing that landlords and social housing providers need to come into the conversation as well, or even ensuring that ethnic and cultural specific nuances are accounted for in that engagement approach, or even age specific tactics and messaging that needs to be considered. And most, I think, as we've seen, the value of even bringing in religious conversation and faith leaders at the local level. to help nurture and bring in that full scope of conversation for where the public dialogue and the public discourse really is happening. And it's important to flag, to highlight, to really name the superheroes of what's happened. The cornerstone of the engagement approach is the ambassadors, trained peer leaders of over 600 different residents from across the city. Residents who have had longstanding trust in their communities, that have been active in different spaces for as long as we've been doing this work in community development, and even before that, without our knowledge. So active leaders, community members who reflect Toronto, reflect Toronto's equity deserving groups, and mirror the city right back to itself, both in culture and race or language and age. Community leaders who raise their hands at the early days of the pandemic, at the early days of the vaccine, and says, I want to offer my time, my passion, my commitment to keep my community safer and healthier. Residents who say yes to building vaccine confidence day in, day out amongst their peers, amongst their networks, and helping navigate those things, going door to door even across public spaces or in buildings or in towers across the city, providing access to information, demystifying public health messaging and amplifying those messages. And it has certainly paid off, but they're community members who hold the trust of their community well. They hold the trust of their community well, and that's important to note because they're able to balance that against the systemic oppression and exploitation that many vulnerable and racialized groups have experienced at the hands of government and medical institutions. And community leaders, they're community leaders through and through, whose commitment to their community, I would say, and I always say, are the credentials that they bring for the health promotion efforts that they do. And I believe that it's this partnership with community, this partnership with the entire community, health providers, agencies, residents, grassroots groups alike, that has enabled such a dynamic and effective vaccine program for Toronto. For us, vaccine engagement has been created by community-driven and community-implemented solution. It's an ABCD, asset-based community development, as can be, for the neighborhood, by the neighborhood, with the neighborhood. And it's this posture of community development, of resident leadership, of capacity building, organizing, that our city division and our unit have been able to contribute uniquely to the overall vaccine program. And definitely hand in hand with a host of other divisions, including, and most importantly, CPH, Toronto Public Health, to really help making sure that that information and navigating these systems internally are helping from our end run as smoothly as they can. And important to note again that this social infrastructure that we speak of, ambassadors, resident partnership, resident connections, organizational networks, partnerships, that social infrastructure has been years in the making. And the social development division of the city has been at the forefront of that, trying to build trust, resilience, and leadership in communities across Toronto. Because much like wherever we are all coming from, across Canada, in any municipality or town or community, inequity is real, and it needs to be named, and it needs to be responded to and acted on. And systemic inequality and discrimination remains, and we know that has continued effects on whether it be health or social and economic outcomes for equity-deserving groups and racialized groups. And so consider that the years of work, the progress made on place-based strategies that we've done for community development, or system-based work that we've done with poverty reduction strategies or community benefits frameworks, or our population-specific strategies like our youth equity strategy or our action plan to confront anti-Black racism. Decades of work in the making, helping respond to social inequity, have created, I would say, the fertile soil for this vaccine engagement work to really take root and to be fruitful. And if anything, COVID-19 and the vaccine program really helped create the conditions for that social infrastructure to come together so well, with a common focus and with a common vision. It brought together the needed players and partners in community into the same conversation. For the first time, I would say ever, everyone was on the same page as far as exactly what they were doing, what they were working for, and what the goal was. All were on board with the vaccine program and saw the benefit and need for that. It leveraged the different skill sets and tools that different partners, like an age-based agency or an arts-based agency, could bring to the conversation to help find a new and creative way to engage with a group. It helped draw bold lines where dotted lines had been before, and visible connections were before. And most importantly, it gave agency to everyday residents to be leaders in their community. And I think it taught us that public health promotion can indeed be done by informally trained residents who care so much more for their community than you or I will ever have the capacity or latitude to do. And so it's a pleasure to see that work come to fruition and begin to think through how we can move that forward, not just on the vaccine front, but for a host of other social issues and health issues that remain and have been intensified in this pressure cooker of COVID-19 for the last couple of years. So with that, I'll pass it back and yield back to Claire.
Well, thank you, Daniel. And there's lots of appreciation, or a couple of appreciations coming into the chat box for all of you, all of the speakers, and for you, Kate. But Daniel, thanks for that just incredible story and illustration of, I'm going to go back over to what Andrew said about that humility, right? Just walking in humility and being humbled by the strength of the community. So I want to give Kate a couple of minutes in about 5 or 6 minutes just to close us out. And there are a few questions, and Daniel, you actually answered a few of them from Retha, and she outlined that it was a great opportunity to hear from people who are actually making the change, who are actually in places in those systems that are actually making the change, and to hear about the strength that needs to be tapped from the community. There's one question here that came from Eileen. And what she's saying, and given the success of the Community Ambassador Program, who do they report to? Who should be leading the training of community ambassadors? That themes come through. Will it be continued? How is it funded? So maybe if one or the other of you, and then there was an early question, and Andrew, I think you might want to pick this one up. Do you think there'll be a change to value-based healthcare, a value-based healthcare framework from a fee-for-service model in the future? And that kind of takes it back to some of the structural pieces that Kate was talking about. So in terms of the Community Ambassador Program, maybe first, does somebody want to pick that up? Daniel?
Just on mute, Daniel.
Thank you, Joe. I didn't get too ahead of myself, but yeah, I'm happy to answer that one. Great question. On the training front, we, alongside Toronto Public Health, and worked with a variety of agencies and trainers, specifically looking to build capacity where it was needed and named by ambassadors. And so there, at the onset of the rollout of the vaccine rollout, there was an initial onboarding that took place that really brought in behavioral scientists and thought leaders as far as how to have a conversation with those that are on various sides of saying yes or saying no, and the movable middle, and how to have that. And so there's some of that foundation level work that was really provided to our ambassadors. And we've, for all training that we've provided, we've kept record of it. There's videos, there's a mini training portal that we've developed to help kind of for new ambassadors that come on, and new ambassadors come on all the time, that curriculum, for lack of a better word, is there and able to be accessed to kind of build that knowledge, or even act as a refresher. But there's been trainings for things like I mentioned, engagement, or data, using data to target engagement, or things like cultural competency. Important right now, and has been for the last little while, is around de-escalation or crisis mitigation in conversations, and the list goes on. There's ABR training that's on deck. There is first aid certification that's on deck, and a host of other trainings. And I think maybe this is the point, that the centralized network that is there, and the ability to really streamline some of that training to level the playing field across the city with ambassadors across the city, is a value add that we, as the city and the municipality and SDFNA and social development, the division that I work with, is able to bring and contribute to. But alongside that, local agencies also providing training, providing that point of contact. They being ambassadors, officially report to local agencies, and local agencies curate, problem solves, and build capacity in the ways that we do. And our role really is to make sure that those systems are set up smoothly to both talk to each other, to talk to us, so that we can learn from them and evolve and adapt as needed.
That's great, Daniel. Thank you. And, maybe, well, I'm going to go to Joe and then to Andrew. You could, if there's any resources or even your contact information, if people want to know more about that, Daniel, if you could put that in the chat, or we can share that afterwards. So Joe, you've got your hand up. Well,
I just wanted to build upon that. Daniel spoke to the structure and the reporting. listen, the vaccine engagement teams, these are 200 agencies who are engaged, community leadership, along with 600 ambassadors. That's a $16 million program. This was funded by the City of Toronto, and that was a direction. It was a $10 million program that was extended until July of 2022 to support the continued second dose and then third dose uptake. So I think this is to Kate's presentation. To support community, you need to resource community. It's not enough to say it. You got to actually put money into it. So it's a $16 million campaign directly into community agencies and ambassadors. The future, and this is where Andrew here has been so stellar on this. We didn't build a whole of government community resourced vaccination campaign model only to shut it down at the end of a vaccination campaign. The future here is to pivot this infrastructure, community-based infrastructure, first towards a more integrated model of COVID care, from testing to access to treatments to access to vaccinations. But then secondly, and more importantly, is how do you build upon this community-based resourced model to support other preventative care on the ground services, from diabetes screening to cancer screening. I mean, this is bring health and social service delivery into the community, resourced and delivered by community. That's the future, but you got to fund it and you got to invest in it. And I think that's part of the fight, not the fight, that's part of the path forward in the city, is to make sure that we continue this.
That's great. Thank you so much. And those two sides, from the ground but also from that policy and funding perspective. So Andrew, I'm going to turn the mic over to you. Joe kind of called you out there and said maybe you have something to say about that as well, but also in terms of that funding model or structural piece.
No, I think I'll try to answer both questions, but I did put my hand up and hearing that, and I think it's, Joe's absolutely right. I mean, I think this is something where we've seen the success of health and social care come together for the pandemic, but we can't lose these learnings. We can't lose these investments. And I think as Joe has laid out in terms of, and Daniel as well, of course, around things to diabetes, to chronic disease management and so forth. I mean, I think if we're talking also about data, it's really important, and Daniel and others have alluded to this about pre-pandemic, just the amount of disparity there is on these issues, from diabetes to cancer and primary care access, all of that actually really helping drive the wide, and I would just say cruel health outcomes that have been desensitized seemingly, or again, speaking to this being about systemic discrimination. Why would we allow this gap to continue and persist? And I think that is really, as Joe put out, I think is right, as a fight of all the people in the room, of the great work that everyone in the room is doing as public health and health leaders and in social policy, if this is not going to be an awakening of where we need to see reckoning with real models and tangible ways that we can see integration, but also to Kate's report about addressing the causes of the causes, then not only are we going to see COVID, and this is the worry that I have, that is played out for many other pathogens, is that it will be a disease and syndrome primarily for racialized and low-income communities. And living with COVID is going to mean accepting that. And I think all of us in this room are fiercely aligned against that future or reality that is really pressing up on us as we're seeing different measures be lifted. And I think as the point is made, the investments need to be in place, especially within community. I think the one piece I'd also just say is that we've got to upend the way we've been seeing innovation and this conversation around hospitals. Safia and others have spoke so powerfully to, when I was in medical training, the idea is always, well, we have all these innovations in the hospital and it's just about getting it out to different communities. But there's also all these innovations and strength and resilience in communities that we need to see move into hospital. And we need to start seeing this be bi-directional. And I think that is really, about the humility, but also actioning the way we're funding and viewing innovation when we're talking about primary health and better health outcomes. And I hope this is something that is now, completely impossible to look away from, whether you're a policymaker or you're working in any health and community organization. We can start to see meaningful commitments to this, given our history.
Thank you so much, Andrew. I'm going to give Kate the final word here. And if you look at the chat box, our staff are putting some of the resources, our evaluation survey, and other items of kind of operational piece. But Kate, I'm going to turn it to you just to have that final word. You took us here and just sort of take us home, and then we'll sign off. Thanks, Kate.
We have just 1 minute left, so I just want to echo some of the words I heard from this amazing panel of the people who are really doing this work. Trust, humility, accountability, resources, and relationships. I mean, this is what really matters in making this community leadership and community work happen. And while we do need the resources, and that those are absolutely key, and it was the relationships amongst this group and many others that really enabled that to happen. And the expertise of communities, but also those of us who are also community members and work in different parts of our institutions and systems. So I know that at this time of renewed austerity, a push to learn to live with COVID that seems to mean pretending we don't have COVID and no longer focusing on equity. We're worried about our funding, and this is something that's been true of public health for a long time. But I hope you can see from this example that, community with even fewer resources got this ball rolling with their leadership and with their relationships. And it was those wise leaders around this table and many others who recognized that and started to step in to provide support to the leadership that, again, was being provided by the experts in community. So I encourage you, don't wait for resources, make those resources happen, work with your elected officials, build the relationships. And we'll continue building this work, sometimes from the grassroots up. Thanks so much for being here. Thank you, Claire, for hosting. And thank you sincerely to all the panelists from Toronto. We really look forward to seeing where this takes you next.
Thank you, everybody. Have a great day and stay safe, and we'll see you soon. Bye now. Thanks, everybody.